Ladies and gentlemen, welcome to this marathon web series, Day 5, Challenges in Hematology, which also includes the best of EHA 2022 under the aegis of Mumbai Hematology Group. We are extremely proud to get associated with Mumbai Hematology Group, and our program director, an inspiration to us, who is president of Mumbai Hematology Group, teacher of teachers, and no wonder, sir, that you have been awarded the Inspiring Hematologist of India by prestigious Economics Time. A warm welcome to all the three experts who are going to speak to us today. Expert discussions who would be making it enriching and lively. And last but not the least, a warm welcome to all the delegates from various countries who are logging in large numbers, including the Day 5 today. May I request Professor Dr. M.B. Agrawal, sir, to take it forward from here.
Thank you, Dr. Manoj. Good evening, or good afternoon, and good morning to all the delegates from various parts of the world. Okay, so challenges in hematology, including the EHA 2022, the 27th Congress of EHA. Today is Day 5 of our web series. It's brought to you by Mumbai Hematology Group, supported by INTAS, managed by Perfect Square. I thank Dr. Manoj and his team from INTAS, Yash, Mr. Kalpesh, and the team from Perfect Square, the Executive Committee of Mumbai Hematology Group, all our discussants who are themselves eminent hematologists or hematopathologists or medical oncologists, and you participants for sparing your Friday evening or afternoon or morning. As I always say, do visit the website of Mumbai Hematology Group. You will get all the information about what we have been doing and what we are going to do in the next 2 months. mhgindia.com. So pretty simple to remember. Just go to that site, download the programs, and keep yourself free. These are something fantastic and very, very highly educational programs. So today, guest speaker for the first lecture is Dr. János Kappelmayer from Hungary. He's from the Department of Lab Medicine, Faculty of Medicine, University of Debrecen in Hungary, and he's going to speak to us today on lab diagnosis and interpretation of coagulation disorders. So over to you, sir.
Thank you. And let me share my screen. Oh, hold on. Azt mondja, hogy akkor ezt először megnyitom. És akkor inkább kiteszem a desktopra. Just a moment.
Take your time, sir.
I will put it onto the desktop. Mert ott a legjobb online India. Okay. All right. Okay. So now. So, is it visible?
Perfect.
All right, thank you. And thank you for the invitation. And good evening, good morning, good night, whatever, because I've seen there are so many people from so many countries. So I'm grateful for this invitation. This is a nice opportunity. I participated at the EHA in Vienna, but this is a totally different feeling, talking to so many people from so many countries. So a short introduction. India is here. Hungary, as you see, is quite far. If we enlarge it, we can see that it's a relatively small country, particularly compared to India. Many people may have heard about our capital city, which is Budapest. I'm speaking from Eastern Hungary, which is 230 kilometers from Budapest, place called Debrecen. This is our major university building, which is close to 100 years old. And it's a nice campus in a forest. I'm talking right now from one of these buildings from here. My specialty is laboratory medicine, and I thought I will start with a little philosophical question. Whether do we need any interpretation for general laboratory results? Quite clearly, the answer is no. We produce about 5 to 6 million tests a year in our laboratory, and this is put into about 800,000 separate reports. And in about 98% of those, there is no interpretation, not required. However, if we ask whether is interpretation needed for lab results that were sent for evaluating coagulation disorders, then the answer yes, nearly always. Now, here's some interpretation issues are important to consider. First is whether the patient is on anticoagulant or is not on anticoagulant. One may think this is an easy question. Why have a third option? In many cases, in real life situation, there are many not sure and maybe. Just consider people who get into an accident. You may not be aware whether that person is on any of the oral anticoagulants, etc. So there are these maybe situations. And as a other interpretation issue, I think we have to talk a little bit about the tests involved. And here are, first of all, the well-known clotting assays, worldwide used the PT, APTT, fibrinogen. And many of these, when prolonged, are using mixing studies. I'm not going to focus on these because the subsequent lecture will probably highlight it very nicely. But I'm going to speak about two other tests that are probably not as well spread as the first three, the thrombin time and Reptilex time. Then there is another bunch of tests that is different from the clotting assays, since there in the clotting assays, we are measuring fibrin formation, and the time required for that is usually seconds. While in a relatively newly developed system, I would say like 15, 20 years ago, that has been more commercialized. It was discovered previously, of course, called thrombin generation assay. We're measuring the generated thrombin throughout a much longer time period, which is many minutes. Usually we follow it up to 1 hour. And there are different types of thrombin generation assays, here shown in the acronym TGA. And another assay group is when we analyze whole blood samples, which is really close to the real life situation. Probably several labs use the platelet function analyzer, ROTEM, or ClotPro assays. For sake of time, I will not have time to deal with all these, of course, in detail, and I have to focus on some of these, so I'd rather focus on the ones that are shown in black. So first, let's see whether the patient is or is not on an anticoagulant. In order to be able to evaluate this, I would like to remind everyone for this slide that is derived from the journal CCLM, written by Giuseppe Lippi, who publishes in many areas of laboratory medicine, and one of that is hemostasis testing. And this figure nicely depicts the old anticoagulants that are the vitamin K antagonists that are inhibiting the vitamin K dependent factors, as shown here in factors 2, 7, 9, and 10. And as well as other anticoagulants that are the low molecular weight heparins that are mostly inhibiting factor 10 and a little less factor 2. And then here are the NOACs, or more recently rather called DOACs, direct oral anticoagulants, the direct 10 inhibitor dabigatran, and the factor 10A inhibitor Xaban, as it's called, rivaroxaban, apixaban, and edoxaban. So the question is that if we do a little training and we look at patient samples, whether we can figure out, suppose that this is a patient that is taken to an emergency room and is bleeding, and we don't know what the reason is, and we cannot get any anamnestic data, can we figure out whether the patient is or is not on anticoagulant? Now, let's see these times. These are the controls here. Prothrombin time being 8.8 seconds, APTT roughly 29, and the thrombin time about 18 seconds. In this first patient, as you see, there's a prolongation of PT. Obviously, INR is elevated, a prolongation of APTT, and thrombin time is basically normal, this non-significant prolongation. In the second one, everything is normal except that APTT is not. When can we say that a clotting time is prolonged? Now, in case of APTT, the general recommendation is 9 seconds over the control value. So since this is over that range, this is a slightly prolonged APTT. How about the last one? A prolonged PT, INR a little elevated, and APTT also somewhat prolonged, normal thrombin time. Any of these correspond to an oral or other anticoagulant? The answer is yes. First is most probably, or could be, of course, it can be other reasons, but it can be vitamin K antagonist. The next is a finding that we see quite often when patients are treated with low molecular weight heparin. In many cases, by the way, the APTT is also normal, but this could be slightly prolonged. And a third one could be a patient on rivaroxaban, which is a factor 10 inhibitor, prolongs both PT and APTT. Now, one may think, why do we have this thrombin time here all the time? It doesn't play any role. Now, let's see 3 other cases where it definitely does. Look at this. First, normal PT, really prolonged APTT, unmeasurable thrombin time. And here comes something. Thrombin time in the presence of polybrine. What is polybrine doing? Polybrine is binding heparin. So in a lab, you can differentiate whether a thrombin time prolongation is due to the presence of heparin or to something else. In this case, looks like yes, because in case of heparin, it was normalized. How about the next one? PT also prolonged. APTT thrombin time is really very prolonged. Even if you use polybrine, it's still prolonged. But if you use a higher concentration, nearly goes back to normal. While in the last one, this thrombin time is prolonged only, APTT also, but not the PT, but polybrine doesn't normalize it. So another 3 cases that could be due to unfractionated heparin. Look how this one is similar to this one, which is dabigatran. The major difference being that here you cannot normalize by the addition of polybrine. While here in the middle, it could be derived from a patient with excessive unfractionated heparin. So I think these small examples will shed some light on the usefulness of screening tests and on the more detailed evaluation of the prolongation. This is not enough, by the way, to establish whether a patient who is on DOAC is in the therapeutic range, because those, as you see from this paper, PT for rivaroxaban and maybe the APTT for dabigatran is only good for screening, but the quantitation in all cases is a proper anti-10A assay with the appropriate calibrator. And here, in case of dabigatran, it's a dilute thrombin time, or in other words, occurring clotting time. So those are the tests that can be used for the actual measurement whether those drugs are in the therapeutic range. Interpretation issues. There are lots of these when a patient is on a DOAC, say dabigatran, like 0.24 microgram per ml is a therapeutic range, because you may not be aware of this. And at the same time, you may have an evaluation for different hemostatic alterations. Now look at this. APTT, as we've seen before, is considerably prolonged with this concentration, even higher concentration, even more prolongation. But also, if you measure fibrinogen, you can see that it's underestimated here. And if you measure any clotting or coagulation factor activity, there's a considerable underestimation here. And if you measure other tests, like if the patient is evaluated for thrombophilia, look at this considerable overestimation when the patient is on dabigatran. So what can you do then? If you say that we cannot skip the drug, how can we do any measurements? So the way to act this way is to consider using DOAC stop. It looks like a charcoal type tablet that you have to put into 1 ml of citrated plasma. Then it will dissolve and the whole thing will become very black, and you spin it down and then it becomes totally clear. And we did several measurements in our lab, and it's been published by other authors that this DOAC stop can effectively be used for neutralizing the DOACs. Quite like maybe we did that test for heparin in polybrin, or if the heparin is in the patient sample, we can also neutralize that by an enzyme called hepsin. I would like to switch a little bit to another anticoagulant and to a potential side effect now, which has definitely an interesting historic background. Many of the senior hematologists are probably know this name for several reasons. Harvey Gronick is outstanding hematologist. He had a really brilliant publications. And one of their papers from 1975 from Blood, heparin-induced thrombocytopenia, where they described the first case of a patient who got heparin, as you can see here. And while being treated by heparin, platelet count went down. And then at the same time, they started giving prednisone and it improved. But as they gave back heparin, again came back, and then they switched to warfarin and the patient platelet count got normalized. So this is really the first description of the heparin-induced thrombocytopenia, and it's also indicated that the patient developed thrombosis. As of today, the general recommendation for suspecting heparin-induced thrombocytopenia is to use the 40 score. This is a pretest probability score where you give 0, 1, or 2 points to these 4 questions, all commencing by a T. So what is the degree of thrombocytopenia? What was the time when it developed? As you see, the 2 points, the largest is given when it's developed between 5 to 10 days. Whether there are any other thrombosis in a patient, so new thrombosis, skin necrosis, and whether thrombocytopenia could be due to any other cause. So the maximum point, as you can see, could be 8. And the high probability of hit is when the score is from 6 to 8. The low is 0 to 3 points, and the intermediate is in between. In all cases in our lab, when we have a request for heparin-induced thrombocytopenia, we contact the clinicians and we take this 40 score. Here are some of the data that I want to show you from our papers a couple of years back. In a controlled person, by flow cytometry, we were checking how the serum from a hit suspected patient can activate normal platelets. These are the platelets here, forward scatter, side scatter. And this is the CD41 fluorescence. You identify the platelets. And by annexin binding, you can see the phosphatidylserine expressing platelets. This is close to 8%. This is the microparticle number in that gate, which is over 2,000. And a large concentration of heparin is a negative control. It scavenges away the effect of HIT. As you see, numbers are the same here. While in a patient who does have HIT, you can see a really high percentage of annexin 5 positive. platelets, and also you can see a lot of microparticles. So we compare these data, annexin 5 positivity on the top, microparticle positivity here, and whether the patient had or did not have thrombosis, with the standard test, which, as I mentioned, is the ELISA for these antibodies, which are directed against platelet factor 4 heparin complex. And in these ELISAs, we plot the optical densities. Optical densities are negative, below 0.3. 0.3 to 5 is kind of borderline. And what you can see here, that the higher the OD, as here as well, the more likely that there is a consequence, a functional consequence of that. So these anti-platelet factor 4 heparin antibodies will most likely activate control platelets by annexin 5 positivity, microparticle generation, or these patients have thrombosis. Now, one question comes up, so where is the role of that 4T score then, if we know this from the lab value? You can appreciate it from this panel. Now look at this. These are our patients where we plotted low probability, intermediate, and high by the 4T score. Now, although the 4T score can be subjective because, yes, the doctor may say, oh, I don't think there is another cause of thrombocytopenia. Oh, there may be, so there could be, how much should it be, 2 points or 1? So there could be some unreliability. But still, if you look at this, the OD values that were having the low probability were variable, but none of these patients had thrombosis, which are indicated by the black signals. Here in intermediate, the ones with the highest had thrombosis, and those with the high 4T score, even somewhat lower OD values provided data were resulting in thrombosis in a patient. Some tests, these were, the half is black. It means that one of the tests was positive and the other one was negative. So this definitely, I think, shows the essence of the 4T score, that this is very useful. And there are also some suggestions that when there is the low probability, it's not really worth doing the test. These are more tedious tests. It's an ELISA test. And the functional test is a flow cytometric test, or the gold standard, as many of you have probably read, is the serotonin release. It's an even more tedious test. And then comes the problems. You learn the textbook and you know the 4T score questions. And one question here is that time of thrombosis. And that time of thrombosis, it should be after day 4. And then it's most likely hit or could be hit. The problem could be when there are these irregular cases. And in one such patient, as you can see, this very severe skin necrosis in another hospital in the region. And the patient was transferred to our hospital, and events were so fast. This is what we got. You can see this skin necrosis progressing to an extreme gangrene in the arm. And the arm couldn't be saved, but the patient's life could, which was good. This was a rapid onset heparin-induced thrombocytopenia, basically started next day after heparin injection. And we could verify from this patient that this is the control value, again, having 8% annexin positivity. This is with the high heparin, which should be the same as the control. And look at this, more than half of a control patient platelet annexin positive by the serum, incubating with the serum of this patient, which means that it's very strongly inducing platelets. It's a very strong platelet activating effect that we could also verify by another technique compared to control. You can see the CD62 fluorescence, CD62. In other words, it's called p-selectin. P-selectin is the alpha granule protein in the platelets. And when platelets are activated, it's transported to the surface. And you can see in these control platelets, when you activate it with the plasma or serum of the patient, it very strongly activates control platelets. So you can understand why this very severe gangrene developed. Okay, so I think so far we were touching one or two examples of how the anticoagulation may interfere with the test that we are doing in the hemostasis lab. Since the audience is mostly consisting of hematologists, I would like to show these few slides from this nice paper by a Danish group, where they have shown that what is the risk of bleeding and thrombosis in those intensive care unit patients who have hematological malignancies. This part of the figure is about the bleedings. And as you can see here, if you take all patients, basically half of those had no bleeding and the other half had. And the WHO criteria, some had very severe, this is grade 4, and going down, some had less severe. Now, if you divide these patients to based on their diagnosis, these were the AML cases, there were myelodysplastic syndromes, ALL, and there were several with hematopoietic stem cell transplants. You can say that basically there are similar percentages, but half of those were bleeding and the other half was not. So we can conclude, yes, they can have bleeding. This could be related to several phenomena, partly also to therapy. Now, the other side is thrombosis. If you take these 116 patients, I think, or so, then you can see that the number of thrombotic events were 9%, and these were the anatomical location, but the hematological diagnosis is interesting because none was having thrombosis from MDS, only 1 from ALL, and 10 from AML. So acute myeloid leukemia patients tended to have thrombosis more than other acute leukemia or MDS patients. Why is that so? I think this figure is just, for most of you, a recapitulation of already known information. I just think the figure is really nice. It's from the International Journal of Hematology by a Japanese author, where he depicts that type of AML, which is well known to be associated with hypercoagulability as well as bleeding. This is the acute promyelocytic leukemia, and this is an APL cell. And that cell is known to express tissue factor. Tissue factor is the most intense activator of blood coagulation. And with the factor 7 together, it further downstream activates the cascade and can cause thrombosis. In addition to that, it may release cancer procoagulant, that is a tyrosine activator, and may release also microparticles as well as cytokines that may indirectly cause thrombosis by doing endothelial damage. I will not deal with this other half of the figure here because this depicts how the APL can contribute to hyperfibrinolysis. I will just want to focus on the left side and show a few studies that we also did with that. And this is the following. So we did 2 different assays. And one assay is described here very nicely in these papers by this Austrian group. This is a global test, the thrombin generation assay. To understand what we are measuring here is that there is a fluorescent substrate that is cleaved by thrombin. And the more substrate is formed, the more fluorescent signal is generated. And all these happen in the presence of calcium. Now, we are not using these as the actual data. These are the raw data. And on the right panel, you can see the actual data that are used, which is a derivation of this, which basically describes the kinetics of the changes, providing a phase where basically no thrombin or very extremely small is generated, then an acceleration phase that results in a time to peak. And from that time on, the speed goes down, which is this part of the curve, and a tail starts. And like I said, the whole procedure goes up to like 50, 60 minutes. So it's a long procedure. The parameters here are time parameters, lag time or time to peak. And the quantitative parameters are the height of the peak, which is expressed in nanomoles, or the area under the curve, which is called ETP, endogenous thrombin potential. Quite obviously, if I ask you, if somebody who generates less thrombin, like somebody is on vitamin K antagonist, you will have a longer lag time, longer time to peak, and a smaller peak. Somebody who generates more thrombin usually will have shorter lag time, higher time to peak. Okay, so this was one of the methods. Our other method for looking at leukemic cells was looking at the fibrin formation when we incubated leukemic cell lines with plasma and recalcified, and then plotted the data here, as you can see in this paper. Monocytes and buffer gave no tissue factor activity, while these three were all monocytic leukemic cell lines that were all giving a coagulation shortening. And if you look on to the right side where we analyze the thrombin formation, you can see this is the monocyte, very small peak and very long lag time, while this is the positive control promyelocytic leukemia, high peak, short lag time. As you can see from these clotting assays, when you do this same test in factor VII deficient plasma, or you incubate by antibody to tissue factor, you basically eliminate the effect. So similarly, we could get the same thing. Times are very long with the non-leukemic cell, while with these leukemic cells, it's short. And if you put them into factor VII deficient plasma or anti-tissue factor antibody, you basically revert this. So what these results mean that many of the leukemic cells can generate thrombin, and this is mostly tissue factor dependent. But for those who are more practical, I would like to show another example that we did, that thrombin generation was also useful to predict poor prognosis after ischemic stroke when patients were on thrombolysis, because we found that compared to controls, that the endogenous thrombin potential as well as the peak was significantly lower in those who had symptomatic intracranial hemorrhage, while the ones who were asymptomatic were basically similar to control. So it means that by this thrombin generation assay, you can also do predictions. And we did also in another study in a lupus anticoagulant patient, we isolated the lupus antibody, and as you see, it prolonged the lag time, but at the same time, it also caused elevation in the peak, and this is in normal plasma, and these two are in factor V Leiden positive plasma, which means that even if the patient has a frequent inborn thrombophilic parameter, even in those cases, lupus anticoagulant presence can further aggravate the situation. And with that further studies, this just shows on the right panel that the target protein for this antibody, the anti-beta-2 GP1, this is the beta-2 GP1, and sometimes when the levels are high, as in lupus anticoagulant patients, as you can see the black bars, they attenuate this effect. So overall, this means that provides a different picture compared to the clotting test. It's a global picture that basically provides information about both bleeding and thrombosis. This is a rare instance that the clotting times are prolonged, but they also enhance the thrombin. This we know about lupus erythematosus because it's prolonging APTT also, but at the same time, it is acquired thrombophilia. In the final part of my talk, I would like to devote some time to congenital disorders. And I think here we have easy and more complicated cases. I don't want to say all easy cases are easy, as you will hear in subsequent lectures, that they could be very tricky. I'm just saying that if there is factor VIII deficiency, we usually see normal PT and prolonged APTT. Same with factor IX deficiency, while if somebody is having factor VII deficiency, it's vice versa. The factor XII deficiency also gives prolonged APTT, but I indicated this in green because we all know that factor XII deficiency, although significantly prolongs the APTT, it does not have any prothrombotic effect. So it's, it does not have any bleeding effect. On contrary, as we all know, the trait is called Hagemann trait. It may contribute to thrombotic tendencies. So it's not a bleeding problem. The more complicated cases are the ones with very rare factor deficiencies or the patients with inhibitors, as you will hear in the next lecture, or patients with non-functional coagulation factors. And then there could be a possibility when you see patients with deficiency of fibrinolysis inhibitors. Well, in my personal practice, this last one we have seen very rarely. But we've seen cases, of course, several of those with inhibitors that can be a real challenge to treat and to diagnose. But we've seen also cases with rare factor deficiencies and non-functional coagulation factors. And I would like to briefly describe these two options. And let's start with the non-functional coagulation factors. And as an example, I will pick fibrinogen. I think all labs measure fibrinogen. Fibrinogen is a key molecule, as you all know. If it's elevated, all these changes that are depicted here are either cause or effect, because it's an acute phase reaction, so that's why it's elevated, and it contributes to higher blood viscosity, clot stiffness, fiber density. You can appreciate these pore size differences here in this nice figure from thrombosis hemostasis. When you want to measure fibrinogen, there are basically two ways, and there is also a third one. This is the state-of-the-art fibrinogen method, which is the gravimetric method depicted here on the right. Basically, you have to clot the plasma, and you have to wash that clot a couple of times, and then you put it on the surface, and then you again wash, and then you put to a glass rod. You basically put your fibrin here and you put it in acetone to dehydrate, and you measure the weight of this. And that will be your fibrinogen mass. This is the kind of gold standard. But of course, all of us, when we are getting a fibrinogen value, we're getting it usually by an activity assay that is named after Klaus, the Klaus method. And alternatively, or in addition, rather, there is an antigen test. Do we require an antigen test? Well, usually no. We only require it when it's needed because there are pathological states. Fibrinogen can be elevated, as you all know, in many disorders. It's an acute phase reaction. So we are not talking just about the decrease. There could be afibrinogenemia, hypo, which is decreased, and dysfibrinogenemia, which is the non-functional fibrinogen, and also could be combined, called hypodysfibrinogenemia. Now, many years back, I was at a meeting where I was told by a couple of experts that dysfibrinogenemia is probably one of the most underdiagnosed disorders in hemostasis. The question could be whether, do we need to diagnose it? Do they have any symptoms? By simple logical evaluation, one may think, yes, probably bleeding, because if there's a coagulation factor that is not working, the patient should be bleeding. Well, the thing is that more than half of the patients with dysfibrinogenemia have no clinical symptoms. About 25% have bleeding, and about 20% have thrombosis. These are the different areas where the pathophysiology may occur. So there could be a disturbance in the fibrinogen-fibrin conversion, or it could be a disturbance of fibrin polymerization, or can be other very rare cases. Now the question is, what should be our testing procedure? I think this is a very nice paper by this author, Susan Shapiro from the UK. And it's a question and answer type of paper published a couple of years ago. And she nicely describes fibrinogen assays, so both activity and concentration, measure PT, APTT, and also thrombin time and reptilase time, and genetic analysis to confirm the diagnosis. If you read other papers, sometimes consensus papers, they don't even mention thrombin time and reptilase time. I by no means want to make a decision on that. I just show our moderate experience. We had 8 cases of patients with dysfibrinogenemia at our university in a period of time. 3 had no symptoms, 2 had thrombosis, actually 1 with severe stroke, ischemic stroke, and 3 with bleeding. We measured, this was the first patient, we didn't measure reptilase time. Reptilase time is very expensive, by the way. But we measured thrombin time, and except for this reptilase time in all cases, reference value is about 18 to 20 seconds. So you can appreciate that all patients had prolonged thrombin time. And many cases, even more prolonged reptilase time, as you can see in these bleeding cases. This is the kind of textbook data from former textbooks that reptilase time is even more sensitive to this than thrombin time. And why I'm saying that this is probably not useless is that we did, of course, the Klaus fibrinogen, and we did an nephelometric assay, and we analyzed fibrinogenetic. And look at this. This patient, by the Klaus method, had a normal fibrinogen, and this patient also, and they both had really prolonged thrombin time and reptilase time. So I think that this dysfibrinogenemia is a more frequent finding than it's reported, and the appropriate screening tests should be used, including these thrombin time and reptilase time values. Finally, I would like to tell you a short story of this young man who had bleeding tendency that began in infancy when he was hospitalized for hemorrhage of the umbilical stump. Now, if there is bleeding from the umbilical stump, and then as you see later, subcutaneous bleeding and hemorrhages from the gum, so this is probably some severe inborn problem. The problem was, however, that the bleeding episodes were treated with fresh frozen plasma that stopped the bleeding, but it was given to him on basically experimental basis without the provision of any exact diagnosis. Because what happened to him, that PT was measured, APTT, thrombin time, and fibrinogen, and they were all normal. And only because everybody was a little bit frustrated not finding anything for this young man, they found a mild platelet secretion defect. And then it was considered to be that, but it was, of course, not in accordance with the clinical symptoms and not in accordance with the ex juvantibus deficiency of the frozen plasma. And when he got to our hospital, look at this very painful hematoma on a thigh. This is the X-ray picture of that, and compared to like the normal one. And it was really huge. So what did we do? Normal screening test still looks like a coagulopathy. There's basically one real possibility, factor 13 deficiency, and in a patient, indeed, it was below 1%. And the B, the factor 13 is of two subunits, A and B, and the B was there. So, and it was not always, not present in the platelets. The good thing in this, that it has a really really long half-life compared to the really short of other factors like factor 7. So the patient is on factor 13 substitution. And as you see, it's sufficient to give around once a month. It's an expensive treatment, and we were lucky because long treatment and no inhibitor was developed. So the diagnosis was made, and he finally could get the right treatment. So to conclude, I just want to show some puzzles, and I think we could have gone for hours of these really interesting area, but I think the use of coagulation screening assays in bleeding and thrombotic cases are essential. And it's important to utilize also methods for assessing the global hemostasis, which you cannot get in those screening assays, and to be aware of the interfering factors. One such thing, as I wanted to show in the examples, is the interference of anticoagulants like the DOACs, or an anticoagulant like heparin. It could be low molecular weight heparin, that elicits life-threatening thrombosis hit, and to be able to adequately interpret the data. I just tell you one example. You see a prolonged APTT in a patient. You may suspect bleeding, but that patient may not bleed at all because that could be factor 12 deficiency. And I've just shown you another example with normal APTT, but severe factor 13 deficiency and severe bleeding symptoms. So I would like to thank my colleagues, particularly our mentor, Professor Musbeck, whom some of you may have heard of. He is very active still today. He's over 80. He's just traveling to the ISTH this time. And these are my colleagues, the doctors from the outpatient unit, and this is our department. So thank you for your attention.
Thank you so much, Dr. János. That was fantastic. The last sentence was superb. Factor 12 versus factor 13. Great. We have some Indian colleagues here who may like to interact with you. And Dr. Krishna Ratna wants to ask you the first question.
Thank you, sir, for an excellent educative talk. Can you please clarify the role of thrombin time? Is it used routinely or only in specific instances, thrombin time?
Thank you very much. Wow, I'm so grateful for that question. We use it all the time. I tell you why. Thrombin time is cheap, number one. Second, you can identify heparin contamination. You can identify presence of DOAC. So when somebody is, or It's very good to identify this fibrinogenemia. Like I've just read this paper, the surgery, the people before surgery, I think it's really useful because the way to identify this fibrinogenemia from in time. Yes.
Thank you.
So it's not a specific test. It's in the panel. PT, APTT, thrombin time fibrinogen.
Thank you. Dr. Venkatesan.
Good evening, sir. Thank you for this nice presentation. I would like to ask, in your laboratory, while doing mixing studies, how do you define your correction? What percentage would you take it as a correction? Conventionally, we say 50% is considered corrected. So what do you use in your laboratory? Do you use specific formulas to address this issue?
Yeah, very good question again. Thank you. I appreciate these questions. We are very strict. I would say the original was we used the 5-second control plus 5 seconds. If it's more than 5 seconds longer than the control, we consider that it's non-correctable. And also, we do the incubations for 2 hours at 37 degrees because some of the inhibitors will not come out at room temperature. So you have to be very cautious and you have to devote the time to that. So I would say you have an APTT control 30 and your patient is 90. It's not 60 in between what you take, but consider the 5 seconds. So if it's over 35, it may be an inhibitor. And then you may have to do Bethesda, what else? It's going to come in the next lecture.
Thank you.
Thank you. Dr. Verma.
Thank you, sir, for your nice talk. Just wanted to know, like you mentioned that the cutoff value for APTT will be almost 9 seconds. So what my concept was that it is around 5 to 6 seconds. So for PT also, what would you suggest will be the cutoff value? Like
okay, thank you. The cutoffs for the 3 screening tests in our lab is for PT 4 seconds, APTT 9 seconds, thrombin time 8 seconds. So these are the, if the prolongations are over this value, we consider it significant. I would not take the 4 or 5 seconds for the APTT for the reason that the variance could be higher, even intra-individual and inter-individual. So in that case, it's a possibility that you overdiagnose some problems. It's a frustration when you find a prolonged APTT and cannot get anything behind.
Thank you, sir.
Thank you. Dr. Prashant.
Hello, sir. It was nice to hear you. I had one doubt. I've seen a lot of patients with nephrotic syndrome have this isolated prolonged APTT. And when you do a mixing study, immediately there will be some correction, but after 2 hours of incubation, that correction is lost, suggesting some non-specific inhibitors. What is the exact mechanism of this? I couldn't get that. Do you have
a very good point. Okay, so in nephrotic syndrome, you have probably hypoproteinemia, of course, and depending on the molecular weight of the individual clotting factors, you may lose those as well. Now, there are ones who are having really high molecular weight, like fibrinogen is one of those, and there are ones who are having a lot lower, like factor 7 is one of those. So depending on the kidney damage, you can lose some of these. So that may interfere with your results, as well as you may lose inhibitors like antithrombin or TFPI, whatever. So that may also interfere with that. But the point you raise is very important because we have about 300 coagulation assays a day, and many of these have APTT, so it's thousands a week, which means that we always obtain prolonged APTTs, where at the back we cannot identify anything. Of course, the most frequent finding is lupus anticoagulant, because that's quite frequent. But if particularly if there's bleeding tendency with no underlying disease, that's when we take very severe corrections, like the acquired hemophilia. That's going to come in the next talk. I'm not going to talk about it. Thank you.
Thank you, sir.
Dr. Venkatesan?
Sir, one more question. In this era of DOACs, how often do you get requests for monitoring of this DOACs?
Oh, okay. I tell you this story. A few years ago, it was not very long, I tell you 3 years ago, we had a speaker from Sweden, and we had asked the same question. So we asked, please tell us whether in Sweden, which is a wealthy country, let's put it this way, how do you do DOAC monitoring? And he said, okay, let me make a few phone calls. And he made a few calls, and 3 outstanding hospitals from the Scandinavian country. One said, we are not doing DOAC measurement. Second said, we are doing once a week. The third said, we are doing 24/7. So as you see, the practices, even in these countries, is very different. As we do it once a week. And when it's required, when it's a bleeding, it's an emergency, we do it so. The most of the requests are for apixaban and rivaroxaban. A lot less for edoxaban and a lot less for dabigatran.
Thanks again. Thanks again.
Thank you. Any more questions? Yes, Dr. Kunal.
Hello.
Yes, Kunal, go ahead.
Yes, my questions is what is the DOAC stop? What is DOAC stop, and is it activated charcoal, or is there any alternative to DOAC stop? And in how many conditions do you have used it, and what is the amount of DOAC stop you have used? Can you throw more light on it?
This is protected by the brand name, so they're not providing what is in there. It looks like a charcoal, but probably with something. We just measured whether it does interfere with any of the other assays. We used it in maximum, probably 24 cases, not more than that, for in the last 1-2 years. And it's basically, you get a tablet, you put it into 1 ml of plasma, you wait till it dissolves, and you spin down the plasma, and then it's clear, and then you take the supernatant and do the test from there. So that is how it goes. The exact composition is not provided in the leaflet.
Have you tried activated charcoal instead of this?
No, but I bet it would probably work, but and then you can be worried about the non-specific bindings, whether you remove other proteins that are necessary. And we did not experiment with that.
Okay. Thank you, sir.
Thank you. Any more questions, please? If no, then thank you very much, sir. We are enriched with a lot of knowledge and a lot of information and practical tips. Grateful to you for having accepted to come on this forum and share your intelligence, knowledge, experience of decades with us. Thank you very much.
Thank you. The pleasure is mine. Thank you very much for having me. Bye-bye.
Bye, sir. And we'll move on to the second talk of the day. We have Dr. Andreas Tiede from Germany. To introduce him is Professor, MD, PhD, Professor of Hemostasis and Thrombosis, Hanover Medical School, Senior Consultant Physician in Department of Hematology, Hemostasis, Oncology, Stem Cell Transplantation, Hanover, Germany. And he's going to speak to us on acquired hemostatic disorders, acquired hemophilia, acquired von Willebrand disease, and others. So over to you, sir.
Thanks you all for having me in your Mumbai Special Hematology conference. It's great to see that hemostasis and coagulation plays such a big role for you. Sometimes here in Europe, we think we are so small compared to the leukemia field, and so you actually do us a favor. I try to share my screen now.
Yes.
Hope that it works. Can you give me some feedback if you see the slides?
Yes, sir.
Oh, excellent. Thanks so much. So I have a couple of disclosures. We used to work together with pharmaceutical companies in studies. They are listed here, and I also gave paid lectures or consultancy for some of these countries listed here. So I think when we talk about severe acquired hemostasis disorders, we have to make a distinction between, let's say, acquired hemostasis disorders that are very frequent in the hospital, that are secondary to bleeding as such, or secondaries to severe infection, sepsis, cancer, large surgery. So you will always see a lot of changes after these situations. This is not what I'm going to talk about today. When I talk about acquired hemostasis disorders today, it's really those rare exceptions that keep us as hematologists extremely busy because they are rare. They are usually extremely severe, and they need usually unusual management to be treated successfully. So when you see this picture here, it is already a type of bleeding that is quite uncommon in the hospital. It's from a publication by our Canadian colleague Jean-Marie Saint-Louis. And you see these large subcutaneous suffusions or hematomas, but you also see from the CT scan on the bottom right that these can extend into deep muscle regions. So what do we do if we see an unusual bleed like this? Of course, it all starts with the tests that the previous speaker already explained so nicely and mentioned. So here is a little bit of an overlap. Of course, if we see something like that, we get the usual complete blood count. First, we look if there is severe thrombocytopenia. I'm not saying that severe thrombocytopenia would usually create a picture like the one that I showed you before, but it is something that we, of course, have to exclude. And then we get the basic coagulation laboratory. In Germany, this would usually be the prothrombin time, the activated partial thromboplastin time, and the fibrinogen concentration. I know that there are variations in the world. Fibrinogen is not always on the standard panel. Sometimes people prefer to see the thrombin time, and this was already discussed in the Q&A session after the preceding talk. So, but more or less, you will get your basic coagulation labs. And so let's focus perhaps on the APTT and the PT. So when the APTT is prolonged in a bleeding patient, and only the APTT, there are actually just 3 factors that we have to consider that could be involved in explaining this bleeding. It will be factor 8, factor 9, and factor 11. These are the 3 intrinsic coagulation factors that are associated to a hemorrhagic diathesis, if you like. The contact phase activators, factor 12 and high molecular weight kininogen, prekallikrein, etc. So any deficiency in those factors would cause a prolongation of the APTT. But usually when we want to explain bleeding, we don't have to worry about those factors because their deficiency does not cause bleeding anyway. So it comes all back to these 3 factors, 8, 9, and 11, when we see an isolated APTT prolongation in a bleeding patient. Reversely, when we see an isolated prolongation of the prothrombin time, it can only be factor 7 explaining that. And when we see a combined prolongation of both, then perhaps the common pathway factors come into place. So there are extremely rare cases of isolated factor 10 deficiency, for instance, factor 5 deficiency, etc. Usually, a combined prolongation of APTT and PT directs our thinking towards vitamin K deficiency or vitamin K antagonists or a disseminated intravascular coagulation, but I'm not going to talk about this. I already mentioned these are quite common and usually don't cause much difficulty in the management. So let's go back to the list of those extremely important things. Among the factors explaining bleeding in a patient with a isolated prolonged APTT, factor 8 is by far the most frequent. And when we consider now the acquired factor 8 deficiencies, then acquired hemophilia is by far the most frequent disease causing such acquired factor 8 deficiency. How do I know that a factor 8 deficiency is acquired? Of course, formally, I have to do a good history. So when the patient tells me that he was bleeding all the time, and perhaps he even has an emergency card that says, attention, this patient has hemophilia, then a factor 8 deficiency is probably a congenital hemophilia A. This must be considered, of course, but it is usually very easy to distinguish between congenital hemophilia A that has a long-standing history and acquired hemophilia A that where a sudden onset of severe bleeding is usually the hallmark. Among the acquired factor 8 deficiencies, of course, there is not always acquired hemophilia A the true reason behind it. Sometimes it can be acquired von Willebrand syndrome. So acquired von Willebrand syndrome, I will come back to this a little bit later during the talk, has sometimes also a very low factor 8. So distinguishing between the two is quite easy by measuring von Willebrand factor antigen or von Willebrand factor activity, the ristocetin cofactor. And in very rare cases, last not least, a lupus anticoagulant can be strong enough that it suppresses the factor 8 activity when this is measured by the APTT-dependent method, the one-stage clot assay. Usually lupus anticoagulant causes thrombosis. In just only a handful extreme cases that I have seen in 25 years, a lupus anticoagulant was also causing a bleed in a patient. That was only in rare instances where factor 2 was extremely low. And then we also saw low factor 8 measurements without a specific antibody against factor 8. But really, this is the extreme 1 or 2 cases in 25 years. Acquired von Willebrand syndrome, much more common, but still exceedingly rare. Usually, an acquired factor 8 deficiency will be acquired hemophilia A. So let's talk a little bit about acquired hemophilia A. This is a rare disorder. Here you see the number of cases per million per year. In most of the countries in the world, this is somewhere between 1 and 2 cases per million per year. You see that Italy and Germany have higher incidences, and this is probably due to 2 factors. The first factor is that our population is aging more and more, and acquired hemophilia is age-related. Elderly people have a higher risk than younger people. Plus, we have a much higher awareness and ability to diagnose this disorder 24/7. So here you see that this was not always the case. So a couple of years back, the incidence of acquired hemophilia was also in the order of magnitude of 2 cases per million per year, but then this increased to 5 or 6 per year. And this was really at a time where we did a lot of awareness, education. We had a new diagnostic regime. So if you look hard enough for these cases, you will certainly find more. This is the message. We published, of course, in journals in the country and also internationally about this very typical picture here of patients with large subcutaneous bleeding. We made our surgical colleagues aware of post-operative bleeding complications. And we provided a very simple diagnostic regime. This is a little bit country specific. I will show you. We tell to our physicians and all specialties actually, emergency care, intensive care, gyne-op, general physicians, all types of surgery, ENT, etc., etc. We tell them, if you see a bleeding patient with APTT prolonged, do a factor VIII test, a one-stage clot assay for factor VIII activity right away. So this is something that we cannot recommend everywhere in the world because it's just not available. But in our country, it's quite easy because every hospital is kind of part of a network where they can get special coagulation testing within a day, more or less. So we adapted this to our situation and it turned out to help increasing the number of cases per year. And then when the factor VIII really is reduced, of course, we recommend the next step in confirming the diagnosis with a functional inhibition assay. This is based on the APTT mixing study, if you like. This mixing study was already mentioned in the preceding talk. But here we don't just mix normal plasma and patient plasma and look for a prolongation. Here we take the patient plasma, perform a geometric dilution 1 to 2, 1 to 4, 1 to 8, etc., and mix all these geometrically diluted patient samples with standard human plasma that contains factor VIII. We incubate this for 2 hours and then measure the residual factor VIII activity. And the reciprocal of this, of the dilution, where we see a 50% inhibition, this is the Bethesda inhibitor titer for factor VIII. You can use the same type of assay also for other coagulation factor inhibitors, but as I mentioned before, factor VIII inhibitors are the most frequent by far. So in Germany, we had a registry about acquired hemophilia A, and this registry is continuing to bring out new interesting data on this rare disorder. And I would like to introduce some of these, or to highlight some of the findings that we had over the years. With special emphasis on outcome and prognostic factors and the risk of bleeding in acquired hemophilia A. Here you see that we have an international recommendation that was changed 2 years ago, also because of results from this registry. What is the formal way of diagnosing acquired hemophilia A? I would like to go with you a little bit more into detail here based on the aforementioned international recommendation, because the German recommendation that I mentioned before, this very simple 3-step algorithm, if you like. So it's so simple that I shouldn't even call it an algorithm. A PTT, check factor VIII, and if factor VIII is low, then do the Bethesda assay. Okay, so this is simple, but this is also expensive and requires coagulation laboratories that are available for each and every hospital. So this is not everywhere, but the international recommendation from 2020, this is a more generic recommendation that can be applied to all countries, and also to countries where you don't have factor VIII activity available at all times. And so in this more complex diagnostic algorithm, I would like to highlight that the isolated prolonged APTT is also the first step. But of course, before going any further down the road here, the user of this algorithm, is advised to consider pharmacological anticoagulants. And this can be done by talking to the treating physician or to the patient themselves, or by doing specific laboratory testing like the TT, the thrombin that is sensitive to heparins or direct thrombin inhibitors, and can continue up to anti-10 ASs depending on the clinical situation. So when the isolated prolonged APTT is not explained by pharmacological anticoagulants and not formally known, then an APTT mixing study is the next step. This APTT mixing study is described in great detail in the guideline. Usually you do one measurement immediately, and then after incubation at 37 degrees for 2 hours, you repeat the measurement. And the APTT mixing study is considered prolonged in our lab, but there is no uniform diagnosis if there is at least 5 seconds prolongation over the normal APTT. And when this is progressive after 2 hours, so when the 2-hour result is worse than the immediate mixing study. If a mixing study is fully corrected, then we don't have an inhibitor, then we have to consider intrinsic factor deficiencies. This can still be all these factors here, and when the patient is bleeding, I already told you only 8, 9, and 11 come into play and not factor 12. Factor 12 might be interesting, of course, in non-bleeding patients. It also could be a von Willebrand syndrome, either congenital or acquired. That depends, but it is, of course, if it's von Willebrand, it is because factor VIII would be low. Let's continue this situation here. APTT mixing study is prolonged. Then the guideline recommends to do a factor VIII activity assay. If this activity assay is normal, despite a prolonged APTT mixing study, then it is most likely a lupus anticoagulant. But remember, lupus anticoagulant and bleeding, this is an extremely unusual combination. So this is really excluding here the extreme. Usually the factor VIII activity will be reduced then, and acquired hemophilia A is already very likely. Physicians should consult an expert. The diagnosis should be confirmed by the Bethesda assay. And in those countries where porcine factor VIII is available as a treatment, this is not licensed everywhere, a test for these anti-porcine inhibitors might be of interest. If you have the situation here that factor VIII is reduced, APTT mixing study is prolonged, but the patient is just not bleeding, you might have come across one of these rare lupus anticoagulants that depress factor VIII activity. This can be excluded by doing factor VIII activity in the chromogenic assay, because this is usually not sensitive to lupus anticoagulant, or using an anti-factor VIII ELISA. So you see now everything is red. We can make things quite complicated. If you want to cover everything, it becomes complex. We did this simplification for the German situation, just 3 very simple recommendations, but it depends. Each country must adopt the situation according to their conditions. Let's consider next the acute bleed management if we made a diagnosis of acquired hemophilia A. We have 3 first-line options available. The first option that is available more or less everywhere is recombinant factor 7A or Novo-7. In the near future, there will be other 7A preparations, not only Novo-7, but the basic principle is always the same. These are very high amounts of factor 7A, much higher than the amounts generated under physiological conditions. And such high concentrations of 7A can activate platelets and produce factor 10 at the site, or 10A, activate factor 10 at the site of injury. The usual dosing is 90 micrograms per kilogram, and the starting interval is 2 to 3 hours. When the bleed is stabilized, then we usually consider increasing the dosing interval. So we usually go from 2 to 3, if it's stable, down to 6 hours dosing interval, then 8 hours dosing interval, and then we stop and look what happens. The alternative is APCC, activated partial thromboplastin, or activated prothrombin complex concentrate. It contains the PCC factors, factor 2, 9, 7, 10, but part of them in a pre-activated state. So this is also a drug that generates thrombin. It can be measured very nicely in the thrombin generation assay that my colleague already mentioned. The usual dosing is 50 to 100 units per kilogram given every 8 to 12 hours, but there is a daily maximum of 200 units per kilogram per day, because doses exceeding this threshold have been reported to cause DIC in the patient. If the treatment is successful, same procedure here, clinical assessment of efficacy and then increasing the dosing interval from 8 to 12 to 24 hours, then every other day, and then we usually stop. This guy over here, the third option, is not available everywhere, but when you have it, it's quite nice because you can measure the effects directly. So this is recombinant porcine factor 8. It is generated with the same technology as other recombinant factor products like Advate, Cogenate, etc. But the sequence that is used is not the human factor 8 sequence, but the porcine factor 8 sequence. And this escapes most of the antibodies against factor 8 in acquired hemophilia. The usual dose is 200 units per kilogram, so this is a very high dose, and you may wonder why. It's much more than we usually would choose in terms of replacing factor 8 in a hemophilia patient, where 20, 30, 40 units per kilogram are enough. The point is that sometimes antibodies against human factor 8, these autoantibodies in acquired hemophilia, cross-react also a little bit with the porcine molecule. And just to be sure, the manufacturer chose the dose of 200 units per kilogram. In most patients, you get sky-high factor 8 activity, and you have to reduce the doses for any subsequent dosing. So close monitoring of the factor 8 activity is very much required with this option, with the porcine factor 8, to prevent overshooting factor 8 activity. But if you have this available, it's a really nice way of providing replacement therapy to acquired hemophilia patients. What about human factor VIII, the good old plasma or recombinant standard human factor VIII? Well, so this is today just the last resort if nothing else is available, and it should only be used for patients with low anti-human Bethesda titers because it's really not very effective, and you have to do close monitoring of factor VIII activity anyway. Whatever you use, it's important if something doesn't work that you are brave enough to switch the treatment option, because letting the patient bleed is always very dangerous with regards to the final outcome. I listed here some pros and cons and some references for each of the discussed treatment options. You find this published both in the guideline and also in a paper in the journal Hemostasis. If you're interested in this deepened discussion, we can come back to it during the discussion. Now let's turn perhaps to a completely different treatment modality for acquired hemophilia, and this is immunosuppression. So why immunosuppression? Well, acquired hemophilia is always an acquired factor VIII deficiency because of an autoantibody. And autoantibody disorders can usually be treated as a first line, I should say, with immunosuppressive therapy. In the 2009 recommendation of the or for acquired hemophilia A, it was expressed very strict that all patients with acquired hemophilia A should receive immunosuppressive therapy immediately following diagnosis. So this was quite a strict or even harsh recommendation at that time. In 2020, the same sentence becomes a little bit softened. So today, IST is still recommended in all patients with acquired hemophilia A, but particular caution today is recommended or should be exercised in frail patients. And honestly, most patients with acquired hemophilia A are quite frail when they are first diagnosed, because usually it is a disorder of advanced age and people bleed severely and are usually bedridden and are submitted to the hospital. So in the past, at the time where the 2009 guidelines said immediately immunosuppression to all of them, the German group, the GTH, made a decision how to do this. And the result was the 2010 GTH protocol on immunosuppressive therapy. And here you see how it was done. All patients started on prednisolone only. And this was continued for 3 weeks. And unless it resulted either in partial remission or the next treatment step was contraindicated, we escalated the patient then to cyclophosphamide, oral cyclophosphamide daily, plus prednisolone. And then again 3 weeks, and if it was not successful, the patient was escalated to rituximab plus prednisolone. So a 3-step escalation regime over a total of 10 weeks. There were several reasons why patients were perhaps not escalated. One obvious reason for the good of the patient was that they achieved partial remission or had a continuous improvement during the prednisone cycle and achieved the partial remission soon thereafter. Or cyclophosphamide was perhaps contraindicated, then rituximab was allowed, or the patient had already died. Same after the second step. If the patient achieved partial remission, no further escalation was required. If a continuous improvement was seen, We usually waited and the patient progressed to partial remission. Some patients died again, and then after rituximab, most achieved partial remission, 2 died, and 2 had the observation had to be stopped at the end of the study. So this is how we treated more or less the 102 patients that were treated starting in 2010. And these were the results. We looked for risk factors that would affect the achievement of partial remission, complete remission, and the overall survival. And you see that factor VIII activity at the time of diagnosis was important. The inhibitor concentration trended to be important, but was not statistically significant in this multivariate analysis. Female gender was not important. Age was not important, surprisingly. So here you see that the 95% confidence interval includes the 1. So this is not significant. You may ask why. It was because the WHO performance status was kind of stronger as a risk factor, and it contained also age as a risk factor. You see here that the performance status of the patient was actually one of the most important factors negatively affecting overall survival. So this is the hazard ratio for dying here, 3 times higher if the performance status was worse than 2, and the chance of achieving complete remission was lower by 60% if the WHO performance status was greater than 2. Same for malignancy. Having a malignant associated disorder put patient at a higher risk of dying. So, and from all these factors here that were analyzed in the aforementioned study, we tried to kind of modify a little bit the treatment recommendation in 2020. So you saw the big impact of factor VIII activity on all these factors, and an impact also of the inhibitor concentration. It was not significantly elevated in this analysis here, but in other studies, for instance, the Spanish registry published in Blood Advances, the inhibitor titer turned out to be more important. So in this recommendation here, 2020, you will find factor VIII activity and inhibitor titer. And if the inhibitor titer is low and the factor VIII activity is at least 1% at the time of diagnosis, this guideline recommends to do the same as we did back in 2010 in Germany. Whoops, where's my, but if the factor VIII activity is below 1% or the inhibitor higher than 20 Bethesda units per milliliter, then we would today recommend to combine steroids already from the first week with either cyclophosphamide or rituximab. And then when this does not work, then we would recommend to add cyclophosphamide or rituximab in the good risk group if it had not been successful after 3 to 4 weeks. In the high-risk group, we would add either cyclophosphamide or rituximab, depending on what was not already given in the first 3 to 4 weeks, if the first part was not successful. So you see that there is a simplification, but also a stratification at the same time. We try to adapt the intensity of immunosuppressive regimen these days according to established risk factors. Going back a little bit to the question, why do we do immunosuppressive treatment at all? So I I kind of mentioned, okay, this is an autoimmune disorder, so it's very natural to treat it with immunosuppressive treatment. But in fact, in internal medicine, we treat autoimmune disorders usually only when there is damage to the patient's health. If we have, for instance, an autoimmune thyroid disorder, which is Hashimoto thyroiditis, very prevalent in young women and also men, we just give thyroid hormone. We would never consider to treat this disease with immunosuppression because the alternative treatment is so simple, and the immunosuppression would do more harm than just replacing the hormone. So trying to transfer this perspective a little bit towards acquired hemophilia, the answer is probably we do immunosuppressive treatment in acquired hemophilia to stop the bleeding. Here we analyzed, also from the German data, the risk of bleeding in these patients. On the right-hand figure here, you see that the risk of bleeding is quite high in week 1. It is the highest in patients with below 1% factor VIII activity or 1 to 5. It's a little bit lower, but still you will appreciate that it's quite high for factor VIII activities up to 50%. So a high risk of bleeding. And when we do immunosuppressive treatment, and it was done in this study by the aforementioned regime, then we see that over time, more and more people progress from very low factor VIII activity. In week 0 here, 50% of the patients have no measurable factor VIII, but this is becoming less and less with time. You see 1 to 5%, 5 to 20%, 20 to 50, and over 50. Over time, with this admittedly aggressive immunosuppressive regime, patients are pushed into remission and they stop to bleed. The question is, if you look at this, what is the price for this? So today, in the European studies, the UK study, the European Acquired Hemophilia Registry, the French SACHA study, and also the German GTH study, you see that the risk of fatal bleeding declines with each study. So we seem to do quite a good job in preventing fatal bleeding. But on the other hand, fatal complications of immunosuppression seem to be the bigger problem today. And really the worst data, and I'm sorry to say this, come from our own study, the German study, that had a pretty intense immunosuppressive regime. So the price that we pay for stopping the bleed is that our patients die from complications of immunosuppression. So my objective for the next years is really to reduce these fatal IST complications. And how can we possibly approach this? A possible answer is emicizumab. You know, emicizumab is this wonderful bispecific antibody that binds to factor 9 and to factor 10, because both binding arms here were designed specifically to bring together these two coagulation factors and then activate factor 10 to 10A. So that's emicizumab. It was a huge success story in congenital hemophilia A with or without inhibitors to factor VIII. So why not considering the same drug also in acquired hemophilia A? There are several case reports and one larger series from Vienna, Austria, that were quite successful. The question, however, is when the patient comes with acquired hemophilia, they are already bleeding. So what is the right way of starting a prophylactic drug that is given subcutaneously, has a very long half-life, and usually would be expected to work only after a couple of months. So this will be done in a study that we are currently doing. We will use an accelerated loading regime, then 12 weeks of emicizumab, 24 weeks of follow-up, no immunosuppressive treatment at all. I really want to change gears here. We would like to study if bleeding in acquired hemophilia A can be prevented by a hemostatic agent and not using immunosuppressive treatment. I really hope that I will have the results available sometime next year, and I am very happy to report them and discuss also with your group once it has been finalized. So let's go back to this scheme. You have seen it before. Acquired deficiencies of factor VIII. Most of it is acquired hemophilia A, the disease we were just talking about, antibodies to factor VIII. Severe bleeding, you recognize it by the long APDT, the low factor VIII. You confirm the diagnosis with the Bethesda assay. You use hemostatic treatment to stop the bleeding, usually recombinant factor VIIa or APCC, and then you do immunosuppression to bring the patient into remission. So what about the next piece here on the list, the acquired von Willebrand syndrome? I will dedicate the coming minutes to this one, and then we are going to have our discussion. So acquired von Willebrand syndrome. So this is really a chameleon of diseases. While acquired hemophilia A is quite simple to diagnose because the patients are very similar, or they all, the laboratory values look alike. So factor A is always low, the Bethesda is always high, etc. Here, acquired von Willebrand is much more complex, and this is related to the diverse pathophysiology of the disease. So people can acquire von Willebrand disease by conditions that reduce the biosynthesis of von Willebrand factor. The most prominent examples are hypothyroidism and valproic acid. In this type of acquired von Willebrand syndrome, the disorder is straightforward to diagnose because von Willebrand factor activity and von Willebrand factor antigen will be low. And once you correct the hypothyroidism or replace the valproic acid by some other drug, it will correct by itself without using either von Willebrand concentrates or desmopressin or any other of the diseases or the medications that you know from VWD. Next group of disorders is paraproteins, so usually MGUS. Here is an example of IgG gammopathy. Sometimes it's also IgM. It can be multiple myeloma, also causing a paraprotein. These paraproteins interfere with the von Willebrand factor, form immune complexes, and result in accelerated clearance of von Willebrand factor. This is a problem because unless you get rid of this paraprotein, it will be quite difficult to replace von Willebrand factor with a concentrate or increase it with desmopressin, because there is active removal from the circulation by this paraprotein. In less frequent cases, there are even specific inhibitors, so IgG or IgM antibodies that specifically bind to von Willebrand factor. You can confirm this by using ELISA studies. There is no commercially available assay, but we set up our own assay with recombinant von Willebrand factor as a target, and we can demonstrate that rarely among those patients we have specific anti-factor VIII inhibitory or binding antibodies. In most of the MGUS cases, it's just a paraprotein that forms complexes together with von Willebrand factor without really specific binding that could be confirmed by ELISA. Next group of disorders is those where von Willebrand factor is adsorbed to some cells in the circulation. And these cells are either platelets, so an extremely high platelet count of more than, let's say, 1,000 per nanoliter or 1 million per microliter, results in absorption of the von Willebrand factor. It doesn't really matter if the reason for these super high platelet counts is malignancy, like in essential thrombocythemia or polycythemia vera or whatever, or if it's just reactive or after splenectomy. So the reason doesn't matter a lot. The absorption of von Willebrand factor and the resulting acquired von Willebrand syndrome can occur in all types of these extremely elevated platelet counts. Another way of adsorption of von Willebrand factor to cells is malignancy. So when you have certain types of leukemia or other malignant disorder that metastasize through the blood, you can, in rare cases, see acquired von Willebrand syndrome. And the today by far largest group of acquired von Willebrand syndrome is due to shear stress and proteolysis. The classical reason for this was aortic stenosis. So here at the site of stenosis, there are disturbances in the blood flow, and this would denature the von Willebrand factor molecule and result in cleavage by ADAMTS13. Today, aortic stenosis is not even the most frequent reason for this type of von Willebrand factor destruction, but rather patients on extracorporeal devices such as ECMO or LVAD, the heart support systems. The routine tests can be safely used for some of these pathophysiologies, but a problem really is here this large group of disorders where von Willebrand factor is destroyed by shear stress and subsequent proteolysis. The problem is that von Willebrand antigen and also the ristocetin cofactor assay or the Willebrand activity assay still would be high. So it is very uncertain to exclude acquired von Willebrand disease just based on normal von Willebrand levels from the routine lab. So this is certainly wrong, at least when you have a patient who has one of these associated disorders like aortic stenosis, ECMO, or LVAD. You can do collagen binding, which is a little bit better, but the gold standard here for detecting this type of proteolysis associated destruction of von Willebrand factor is the direct analysis of the multimers of von Willebrand factor. This is done by electrophoretic separation and specific antibody staining of von Willebrand factor. Here you see a series that I made a couple of years ago, and you will appreciate that the characteristics of acquired von Willebrand syndrome associated to cardiovascular disorders is very different from those associated with gammopathy or lymphoproliferative syndromes or paraprotein. You see that the GPs here sometimes have low factor VIII, low Willebrand antigen, low ristocetin cofactor, low collagen binding, and the respective ratios here. But this is never seen in acquired von Willebrand syndrome due to cardiovascular disorders. So here in this group, you see just the reverse. You see high factor VIII, high Willebrand antigen, high ristocetin cofactor, and you can make the diagnosis only by doing the multimer analysis directly. This is the suggested diagnostic algorithm that we prepared in a group between US and Italian physicians and our group in Germany. So von Willebrand testing is suggested in all patients with an acquired or congenital bleeding disorder. When all the tests are normal, including the multimer pattern, then you have to consider something else for your bleeding patient. If any of the von Willebrand tests are reduced, or the multimer pattern is, if the antigen is reduced and the activity assays and the multimer pattern is normal, then you have to consider type 1 von Willebrand disease and the absence of an AVVS associated condition. On the contrary, if you see something like hypothyroidism, valproic acid, etc., then you have to consider acquired von Willebrand syndrome. When the high molecular weight multimers are reduced or absent, and this is the largest group here of people bleeding due to von Willebrand factor disturbances, this will be acquired von Willebrand syndrome in the presence of AVWS associated disorders. If you don't see such disorder, you have to consider type 2 congenital von Willebrand disease. If such an AVWS associated disorder is already present, you may wonder if you have to do the testing also. This is only recommended when the patient is scheduled to undergo surgery with high bleeding risk. Then it is recommended to do all the testing and consider acquired von Willebrand syndrome. What about the treatment? Before you start the treatment of acquired von Willebrand, it's always important to make the correct diagnosis and distinguish cardiovascular defects from gammopathy and other reasons for AVWS. In contrast to acquired hemophilia, almost all patients with acquired von Willebrand syndrome have a reason. So there is no such thing as an idiopathic acquired von Willebrand syndrome, in contrast to acquired hemophilia, where half of the patients are idiopathic. The treatment, as mentioned before, depends a lot on the reason behind acquired von Willebrand syndrome, and this is listed here in this table. So for the more immune-related things like autoimmune associated or gammopathy, MGUS associated acquired von Willebrand syndrome, IVIG is a good way of treating it, because IVIG will result in eliminating these antibodies from their target, and you will usually see a spontaneous increase in von Willebrand factor levels over the next 2, 3, or 4 days. If this is not an option because you need something immediately, the options include plasmapheresis, antifibrinolytics, von Willebrand factor containing concentrates, or recombinant factor 7A. So you have a whole bunch of possibilities here, depending on how the situation of the patient is, if you have planned surgery or if you have an emergency situation with a heavily bleeding patient. For the cardiovascular associated acquired von Willebrand syndrome, corrective surgery is always the first consideration. If that's not possible, as usual in patients on LVAD or very old patients who cannot be operated right away, then von Willebrand factor containing concentrates and antifibrinolytics are a good option. For patients on LVAD specifically, we always recommend to look at the anticoagulant treatment first. So many of the LVAD patients, in particular with the old devices, they still have warfarin plus clopidogrel or some other antiplatelet agent. And usually we reduce or even withdraw this in bleeding patients before we consider to provide VWF concentrates. Patients with the less frequent thrombocythemia or polycythemia, CML-associated myeloproliferative disorders, usually cytoreductive therapy is the treatment of choice. Phlebotomy can also be recommended in polycythemia, tyrosine kinase inhibitors for CML. But for all of them, withdrawing aspirin is a first step usually when you see a bleeding patient with acquired von Willebrand syndrome. In this context, desmopressin is a particularly good option for these patients here. It works much better, according to my experience, than in patients with cardiovascular associated acquired von Willebrand. Desmopressin works quite well. The concentrates, if you have to use a von Willebrand factor containing concentrate, it appears effective in most cases, but you have to remember that the half-life can be very short, so you have to monitor, and sometimes really huge doses are needed to be effective. Desmopressin overall, the reported rates of efficacy are quite low. I would consider it personally in the myeloproliferative disorders for the most part. IVIG is very effective in patients with IgG paraproteins. Recently, we had also some successes with IgM paraproteins, but it is a little bit questionable, so I put a question mark here. You have to do the testing to really see if it's working, yes or no. Tranexamic acid is always a good idea in all these associated or acquired von Willebrand syndromes, and recombinant factor 7A is usually a therapy of the last resort. So, in summary for today, I would like to highlight that the two disorders, acquired hemophilia A and acquired von Willebrand syndrome, are rare disorders of hemostasis, but awareness is absolutely important to save lives, because we need rapid diagnosis and we need hematologists who really dedicate their career to all this little detail to help the patients survive. Intensity of immunosuppression is a problem in acquired hemophilia A, and it is currently under consideration. I hope that we will be able to reduce it. Emicizumab is a promising agent. It is under investigation for acquired hemophilia and perhaps in a couple of years also for acquired von Willebrand syndrome. With this, I would like to thank for your attention.
Thank you so much, Dr. Tiede. That was beautiful. Let's see if our colleagues have some questions for you.
Happy to take them.
Yeah, sure. Dr. Verma. We can't hear you, Dr. Verma. No, we still can't.
Yeah. Hello.
Yeah, yes, now go ahead.
So during treatment of acquired hemophilia, you mentioned that you monitor the patients, and then every 3 weeks you just decide on whether we have to add cyclophosphamide or you have to go for rituximab. So what is the monitoring parameters during this period? Do you look for APTTs or Bethesda titers or the clinical response and during this to just make a decision that you have to add cyclophosphamide or rituximab?
Yeah, so the deciding factor, the laboratory test that I consider most important is factor 8 activity. So when you see the factor 8 activity is rising, I would not escalate the immunosuppression, I would wait. If you see that there is no effect on the factor 8 activity, I would do the escalation after 3 weeks. In cases of doubt, you can also look at the Bethesda titer and repeat this one. If you see that it drops and drops and drops, that's a good sign. But of course, this is the much more expensive assay, and usually factor VIII activity is enough.
Thank you, sir. My another question is, like you mentioned that in post-splenectomy cases, sometimes the thrombocytosis is extreme. And you mentioned that even the acquired VWD can occur with those cases also post-splenectomy. So do you routinely recommend cytoreduction in these patients who are having, platelet count more than 10 lakh or 1,000?
No, never. So usually the problem is only for some limited period of time. And I recommend then not to do any anticoagulation or antiplatelet therapies. When you have an abdominal surgeon who sees that the platelet counts rises to 1 million or more after splenectomy, usually they call you and ask for aspirin and anticoagulants, etc. And I recommend normal thromboprophylaxis for all of them because they are surgical patients. But if they are bleeding and I suspect this mechanism of von Willebrand factor adsorption and acquired von Willebrand disease, I stop all of this and just wait, and usually it is enough. I have seen only very few cases where we had to give some Willebrand factor extra in these cases. This is the exception and not the rule, but never use cytoreductive treatment for reactive thrombocytosis after splenectomy.
Thank you.
Thank you. Dr. Prashant.
Hello, sir. It was wonderful. Actually, I revisited my previous experience. I had actually 2 patients, but they were acquired hemophilia B. They were not A, B. Both of them, one patient, the B levels were 3%, other patient was 9%, with both of them, the Bethesda units going above 100. And both of them had multiple myeloma, frank multiple myeloma. So I had treated them, both of them, with the cyclophosphamide, bortezomib, dexamethasone combination because they had myeloma. One patient responded very well. But for monetary reasons, the Bethesda unit and the factor assay was not monitored. Only APTT I was monitoring. One patient actually did not, one patient's APTT did not reduce, even though the myeloma came under control. He survived for almost 9 months, but with the prolonged APTT, not much of a bleeding. But then one day, suddenly he had an intracranial bleed and he died. So in retrospect, I'm just wondering now, would addition of rituximab for this patient would have helped? Because I had given cyclophosphamide and dexamethasone, 2 of the good drugs for acquired hemophilia. So whether, not just inhibiting the plasma cells, other B cells also by giving rituximab, would it have helped in this patient?
Yeah. Okay, so my first reaction is, wow. 1 doctor and 2 cases of acquired hemophilia B. But this is India, right? So yeah. You are double the population of Europe. So even yeah. So even if I increase my catchment area by a factor of 10, it will still be smaller than yours. And so that's the reason here. So everything is possible, and most likely it occurs either in India or China, because you are the biggest countries in the world. So I have no personal experience with the situation that you mentioned. I would have done it just as you did, treating the myeloma and observing the inhibitor go away, hopefully. You were successful in case 1. In case 2, you saw a remission of the myeloma, but the inhibitor against factor 9 did not go away. So this reminds me of a situation where sometimes autoimmune phenomena are not directly linked to the paraprotein or the plasma cell clone, but some distant or bystander autoimmunity that has a coincidence in that patient. So, and because of that, in retrospect, you might consider perhaps something like rituximab could be effective, because you don't expect to treat the myeloma then, but perhaps some autoimmunity, antibody-associated autoimmunity that is kind of next to the myeloma. So this is just an idea, but all my respect, I don't have personal experience with such a situation.
Yeah, absolutely, sir. After those two, I never witnessed another acquired hemophilia, either A or B. It was just, by luck, I could diagnose. Thank you.
Yeah. The other option, of course, is daratumumab, because whatever type of cell makes the antibody, you can stop it with this wonderful thing. Yeah.
Okay.
But it's expensive. Yeah.
Thank you.
Thank you. Dr. Prashad?
Yeah, my question is also regarding the autoimmune hemolytic anemia. Once you get the patient into remission, would you continue the immunosuppressive therapy, or would you wait for it? Because in most cases, it's an autoimmune disorder, and all autoimmune disorders need a continued treatment in some form or the other. What's the approach?
Yeah, that's a very good question. So if in many autoimmune diseases, you would continue your treatment a little bit over achieving remission. This does not seem to be necessary in acquired hemophilia A. So I usually stop right away. And I think this is because the true autoimmunity has been stopped already weeks before I see the remission, because the antibody is so long lasting. So this is my personal explanation. But I made very good experience stopping right away. Of course, if the steroid was in the patient for quite some time, I reduced the steroid slowly, just for the patient well-being, not for the autoimmune disease. And the relapse rate is about 20%, but does not seem to be related to having another autoimmune disease, yes or no. I don't see a difference there. So a little bit different to how you would treat acquired hemolytic anemia or other autoimmune disorders. So of course, if anybody has a question and is just considering the time now, because I see my dear colleague Elisabetta already preparing and I'm over time now, just send me an email. Okay, so Professor Agarwal knows my email address. I can also put it in the chat here. So if there are any questions, I'm really happy to answer, because I like those hematological disorders so much.
Thank you. Thank you so much, Dr. Tiede, for being with us. This was fantastic lecture, and you answered a lot of things. And the lecture itself was so informative. With all your personal experience, you made us very rich. Thank you so much.
Oh, that's wonderful feedback. Thanks a lot, and go on. Yeah.
It's a pleasure to now introduce our third speaker of the day. So we have Dr. Elisabetta Abruzzese from Italy. Just a brief introduction of her. She's MD, PhD, doctorate from University of Rome. She's director, Chronic Myeloid Leukemia and Lymphoma Clinic at the Hematology Unit for almost 20 years. She's co-director of the Cytogenetics Hematology Lab from 2004, and then National Scientific Qualification Associate Professor of Hematology from 2017. And she's going to talk to us about Back to the Future, treatment-free remission, and pregnancy in chronic myeloid leukemia. Over to you.
Thank you. Thank you very much. Can you hear me?
Yes.
Okay. I'm gonna share my screen. Can you see the screen?
Yes.
Full screen?
Not yet.
Now?
No.
I can see the screen.
Yeah, so some problem. We can't see it.
Okay, let me try to
Read
do
it.
everything again from the beginning. Can you see it now?
We can see the screen. Yeah, now we can see.
Okay,
Perfect.
all right. Okay, thank you very much, Professor Agrawal, and all the audience, to giving me the opportunity to discuss with you about safe pregnancy and healthy babies in CML, how to do it, and a way back to the future for all our patients. Those are my disclosures. And as you can see, in the past 15 to 20 years, a great amount of information have been produced regarding this subject. And we can see that the prognosis of CML has completely changed in the last 20 years. And a collateral effect of a successful treatment is the expanding the family. As you could see from this chart, it has not been really updated. In the past 10 years, the amount of pregnancy that were carried to term have enormously increased in patients with CML. And the amount of information has clarified many questions, but some unsolved questions still remain. So in this 30 minutes that are following, we will try to discuss about solved and also unsolved questions that are remaining as a question mark for the future. As you can see here, those are in the black, the things that have been solved, and in the red, the things that are not be solved. We are trying to discuss the first three with the little hint on the fourth. We won't have time to discuss of the entire 6 points. So let's start with the first one. Male patient can conceive during therapy. We know about that. And is this true for ponatinib also and newer drugs? What are the data to support this hypothesis? We know that TKIs target multiple kinases, and not only kinases that are related to CML. Some of those are implicated in sperm maturation, implant, and also the embryogenesis. What are the effects of TKIs on those phases of the gonadal formation and also pregnancy? We know for certain that TKIs are all teratogenic and embryotoxic and can cause post-implantation damage, especially at high dosages, but they are not genotoxic or mutagenic in animals. So we can suppose that for what concerns male patient, the sperm cannot be affected by the drug, and so when there's a conception, if the pregnancy goes on, it's gonna be everything all right. One other thing to keep in mind is that all pregnancies, regardless of patients or normal population, have a prevalence of congenital birth defects that are approximately 3%. And some of those birth defects are more common than others. What are the data to support then that if you have a conception in male patient, you don't have problems in the offsprings? Approximately 450 pregnancies in partners of men on therapy have been described. Most of them were, of course, under imatinib, some under nilotinib and dasatinib, a few less with bosutinib, and 2 on ponatinib. Some events have been described in newborns, but apparently they are not related to TKI exposure because similar frequencies are evidenced in the general population. So we can conclude that no problems in conception, pregnancy, delivery, or increase in congenital abnormalities can present in men taking TKIs, but caution is needed with ponatinib and newer drugs because there are not enough information. Recently, systematic review was presented by Saka et al., reporting all published data on male conceiving during treatment, and 428 pregnancies were described from 374 fathers. 400 resulted in live births, and 10 offspring presented with malformation. As you could see, the malformation were quite similar to the one present in the general population, and the amount of incidence of those abnormalities was around 2%, so approximately the one that was reported in the general population. What about the second point? Female patients should not be treated during pregnancy. And of course, this is self-evident, not only for TKIs, but for all kinds of drugs. But if a patient is on therapy because she has a CML, when does she have to stop TKI before conceiving or at conception? To understand this, we need to go back to the embryogenesis and the development of the fetus during pregnancy. We all know that obstetric weeks are counted since the first day of the last menstrual cycle. So before implant and conception, there are still another 2 weeks to come. And in this period, the embryo is not susceptible to teratogenesis. So let's say that until the 4th to 5th week of pregnancy, there should be no problem also if the mother is assuming TKI. We need to distinguish also the period of the major organogenesis, that is the one most susceptible of the action of teratogenetic drugs, and also, of course, TKIs, is among the 6th and the 10th week of gestation. After the 12th week, the majority of organs are already formed, and after 16 weeks, the placenta is formed also, and we will see why this is going to be important. So this is the period that absolutely should not be exposed to TKIs because of the risk of teratogenesis. When then to stop TKI before conceiving? Is necessary to stop TKI before conceiving is not what we suggest at present because of the reason we have just seen. So we suggest that TKI should be stopped at first pregnancy test, meaning among the 4th and the 5th week of gestation. This has been demonstrated also by many database reported that the European Leukemia Net reported 182 patients who conceived on TKI, some with first generation, some also with second generation TKIs, with offspring having no problems about that, and the majority stopped around 4th, 5th weeks. Also, GMEMA presented 56 patients that stopped TKI at first pregnancy test, 17 patients under bosutinib were described, and two pregnancies under ponatinib. But if the patient needs to be treated during pregnancy, how can you treat this patient? When and for how long? Let's say what happened to what has been described of the use of TKIs during pregnancy. More than 300 cases of pregnancy in female patients on imatinib have been described. Fetal abnormalities described were quite peculiar, as you can see, and they are pretty different from the general abnormalities that are usually found in general population. For example, the exomphalos incidence in those patients treated with imatinib during organogenesis has been reported in a frequency of 3 out of 125, while normally incidence is 1 out of 4,000. Also, as you can see, skeletal malformation, myelomeningocele, cerebellar hypoplasia, vascular and organ defect have been described. One positive thing, however, is that imatinib has a little placental crossing. So if really needed, we can consider the eventuality to treat patient after 16th week of pregnancy when placenta has been formed. At the same time, more than 60 cases of female patient pregnancies were reported on nilotinib. There was one abnormality reported that was not, however, reported to be directly connected to the drug. And also for this drug, there is little or no placental crossing. On the contrary, of the 80 female pregnancies reported on dasatinib, 50% of them exposed during first or subsequent trimester. We have evidenced the serious problems, including intrauterine death, omphalocele, organ and skeletal malformation. This is because dasatinib crosses the placenta and can be toxic at any stage of pregnancy. 16 patients have been treated with bosutinib with a remarkable outcome, and 2 pregnancies have been described under ponatinib, and we'll discuss about that later. In order to implement the treatment-free pregnancy with regard to non-TKI option, another drug that can be considered is interferon. As a matter of fact, interferon alpha remains the best therapeutic option in pregnancy. It is safe because it is undetectable in fetal blood, and also it doesn't cross the placenta. However, its use is limited by the slow time to response and so also the daily subcutaneous injection. Recently, polyethylene glycol molecules were attached to interferons to increase the persistence and reduce the side effects. The resulting pegylated interferon alpha are present in 3 commercial forms: pegylated interferon alpha 2A Pegasus, pegylated interferon alpha 2B Pegintron, and also raw peg interferon Besremi that has been recently approved for polycythemia vera. That is a form that is being covalently attached in one site to interferon alpha 2B molecule, and it is administered every 2 to 4 weeks. Those forms have been tested in pregnancy and have resulted very tolerable. Interferon can act in chronic myeloid leukemia, for the youngest that are listening, on three points. The first is the direct inhibition of the leukemic clone. The second point is stimulation of immunocontrol of the immune system on the CML clone. And the third is the immunomodulation of the microenvironment at the stem cell and at bone marrow level. But we must say that interferon are rated as pregnancy category C because there are no large control study like with all those drugs in pregnant women, but potential benefit may warrant its use in pregnant women despite the potential risk. When to use the treatment, it must be introduced another concept, the concept of tumor burden, because tumor burden at pregnancy onset and also time to TKI exposure can predict the need of being treated during pregnancy. As we already said, imatinib teratogeneity has been mostly found during organogenesis. 51 patients were treated beyond the second trimester, and have been reported as uneventful. ELN reported 33 patients, and also little placental transfer has been demonstrated. Nilotinib also has a little placental transfer and occasionally crosses the placenta for 1/3. ELN has described the 7 patients treated after the 21st week, most of them with reduced dosage, 400 milligrams instead of 600 or 800. Dasatinib passes through placenta and should not be used at any time. Interferon, on the contrary, is safe and can be used to maintain remission when transcript level starts to rise. This is another concept that can be introduced, meaning that sometimes TKI can be stopped and interferon started in order to maintain remission and continue or start a pregnancy when the remission is not a deep remission or when the transcript starts to rise. But it's not only a question of TKI, because other things must be considered in a female CML patient. Some are illness related, and of course we cannot preclude about considering the biology of the illness. Are we talking about chronic phase or an advanced phase? The CML status, is this an onset? It's a patient in remission. How deep is the remission? The pregnancy status, we already said the importance of the weeks of gestation and the progress of pregnancy. Also the timing and duration of embryo fetus TKI exposition and the TKI used. There are also very important things that are patient related, basically psychophysiological issue, the age of the patient, the parity, sociocultural, religious environment, willingness, and so on. And also pregnancy related. We can encompass 3 scenarios related to CML and pregnancy. The first is a pregnant patient that has been diagnosed with CML. The second is a patient with CML that plans to get pregnant. And the third is a patient with CML that presents with an unplanned pregnancy. But each case of pregnancy must be individually considered and evaluated. Those are informations regarding patients that are diagnosed during pregnancy that, of course, can be considered the worst scenario. As you can see, those are data from ELN, not published yet, in preparation, and I thank Ekaterina Chelisheva for giving me the opportunity to present those data that we harvested together. We are talking about 85 patients that were diagnosed during pregnancy. For among those 85 patients, the 65 continued the pregnancy, and 64 ended in a childbirth, and 1 is ongoing, while another 20 patients were terminated. 20 pregnancies were terminated. 23 patients were not treated throughout the pregnancy, while 42 patients were treated. 28 with interferon, among those 12 with pegylated interferon, that actually in Europe is the only kind of interferon that you can find. 19 with imatinib and 7 with hydroxyurea. But considering the fact that 35% of patients have not been treated, what are the variables that can be considered? And also, when you need to use TKI or use interferon, you need to consider different things among this subject. First of all, as we already said, risk factor. And second, we must take into consideration that CML is not, happily, an acute leukemia. And before CML at onset can evolve in blast crisis, usually there are 5 years without the use of TKIs. So we can say that unless particular situation, a strict observation till white blood cells are above 100,000 and or platelets are above 1 million, patient can be observed. Interferon, of course, if you need to treat, is the first choice, and then you need to evaluate TKI introduction. But we go back again to the concept of tumor burden that is important both at onset of pregnancy and also during pregnancy, and should guide the treatment start or restart. We know that until patient is in complete cytogenetic remission, there is virtually no risk of progression, as NCCN guidelines suggest, while the risk of progression is present when you have a high tumor burden and also no hematologic complete remission. Further, if you consider that the TFR is possible when you have molecular remission more than 4, those are the kind of a safe option within you can observe the patient or not treat the patient. Another very important point is that we have a strong predictor of evolution, that is the monitoring. Monitoring is very important, of course, especially if patient is not treated and should follow TFR indications. And also we need to consider the kinetics of transcript rise, that in pregnancy is not the same for all patients. Is a variable. There are some patients that have been treated and started pregnancy in MR3, stopped treatment during pregnancy and would not evolve, while other patients in deep molecular response, since a long period of time, stop therapy and relapse after a few months. Now that we know all the pros and the cons, considering the different drug and the different situation that you can imagine, let's talk a little bit about some case report and see how you would apply those recommendations, those guidelines, those indications that were present so far. The different scenarios are, we already said, CML diagnosed during pregnancy and also pregnancy during CML treatment. And this is another concept to be introduced, the time of exposure to TKI, because is this a pregnancy that was present early in CML treatment with a patient that has been treated for less than 2 years, so that should not stop treatment? Is a pregnancy late in CML treatment, but not a TFR candidate? And this also is a tough situation because it's probably a clone that is not easy to be cleaned up and is probably prone to relapse kind of soon. Or is a pregnancy late in CML treatment and a TFR candidate that should, of course, try TFR independently for pregnancy, and this should be the easiest case to be discussed. So the first case encompassed 2 patients that discuss about CML diagnosed during pregnancy and also pregnancy late in CML treatment and TFR candidate. Let's start with the first patient that was diagnosed at 31 years in March 2018 as having a CML. She was at this time pregnant 18 weeks. She had a low SoCal or Euro, but but presented a transcript that was not the common P210, but a P190. qPCR at onset was 80%, karyotype full Philadelphia, no additional abnormalities. She showed up with 47,000 white blood cells, HB 9.9, but she was vegetarian, and so she was receiving iron intravenously, and 627 platelets. This was 18 weeks. We keep following the patient. The RCBC remained stable, and at 38 weeks, white blood cells were 33,000, basically stable. HB was 13 and platelets 426. On August 18, Redip is born at 39 weeks through a cesarean section. As you could see, is one of your connational that lives here. The weight was 300 3 kilograms and a half, and the height was 52 centimeters. The mother was treated with dasatinib, and since 1 year, she is actually in TFR and followed over time. This is another patient diagnosed at 26 years as having a CML, 7 weeks pregnant. At this time, white blood cells were high, and so we needed to start a treatment. She had 900,000 platelets and also about 85,000 white blood cells going up very quickly. So she was started on interferon and low molecular weight heparin at 8 weeks of pregnancy. At 19 weeks, she achieved the complete hematologic remission. At 3 months, also cytogenetic kind of had a little answer, but this was expectable because interferon is slow to act. And on March 2018, Sabrina was born at 38 weeks plus 2 weeks. That's Sabrina now. The patient was placed on dasatinib. The drug was well tolerated, and in 9 months after delivery, she was achieving deep molecular remission that was maintained since 2018 until 2021. When she stopped dasatinib to get pregnant again, she turned positive with her pregnancy test right away, but at 13 weeks, she already lost MR3. And at 24 weeks, she had 9.2 qPCR. So she was started on pegylated interferon, and on June 2022, after 3 weeks of interferon, the PCR already dropped to 4%. And we are waiting for Samuele to come on August. The other case is a pregnancy early in CML treatment. A patient that presented with less than 2 years treatment was a patient aged 24. She was diagnosed as having CML diagnosis on June, but she didn't want to start treatment because she was getting married. In August 2018, she started imatinib, but had some problem and also not a good response. So she was switched to nilotinib 600 milligrams. The new drug was well tolerated, and slowly at 12 months, she achieved major molecular remission. After 1 year of treatment, she came to our clinic for consultancy because she wanted to get pregnant. But we suggested to consolidate response for another year and wait, even if she was not willing too much to wait. She started anyway documents and procedure for a medical assisted reproduction. On February, she had a harvest of her oocyte, and in May, her qPCR was 0.005. She had an ICSI with an embryo 5 days old. Pregnancy test was positive the 30th of July, and she stopped nilotinib, and she was strictly controlled until at 13 weeks. She also lost major molecular response that was confirmed in a subsequent test. We discussed this, then the possibility to wait and restart nilotinib if qPCR was above 1, or start pegylated interferon right away. Since she wanted to breastfeed, she was placed on pegylated interferon, 90 micrograms. She maintained the MR2, MR3, and on April 15, Flavia was born with a spontaneous delivery. And on June 2018, she's still on pegylated interferon. With a test, this has not been updated, but she's still on an MR3, and she's breastfeeding. The third patient is a patient that presented in the scenario of pregnancy late in CML treatment and not TFR candidate. is a patient 31 years old. She was diagnosed during preconceptional exams as having a CML. She was placed on nilotinib, but at 18 months, she was still on MR2. The Sanger sequencing was negative for mutation, but in light of a deepening response, discussion was done with the patient to consider changing therapy. She changed then treatment to dasatinib in September 2015, but after 21 months, she was still in MR2. This young patient is in MR2 after 39 months of 2 second-generation TKIs with no mutation. Transplant must be discussed. The patient wants to pursue pregnancy, so she's placed on ponatinib on June 2017. After 3 months, she has an MRT, but after that, she is again in MR2. March 2018 revealed a mutation that is not, however, clinically significant. Her sister is not compatible, and she starts for a donor search. On June 2018, patient is addressed to our Center for Fertility Preservation. Patient at this time is 35 years old. She's scared, depressed, well-informed concerning her illness and prognosis. She wants to start pregnancy before transplant, knowing that she'll probably enter early menopause after that. We decide then to add interferon to ponatinib in light of TKI stop at conception and interferon maintenance throughout the pregnancy. She fortunately achieved deep molecular response after adding interferon, and we give the okay for attempt conception. She got pregnant, but she had a miscarriage. She maintains MR4 and stopped interferon during summer for a vacation. She was traveling with Australia, and so it was complicated. After stopping interferon, she maintained ponatinib. After coming back, ponatinib was also reduced as manufacturer's indication because she presented with an MR4 stable, and then it comes lockdown. Patient stayed at home and the pregnancy test starts positive. We always had the interferon in the fridge, and we stopped ponatinib, crossing our finger, ready to restart interferon as soon as the response, the transcript was going up. But as you could see on the left side of the screen, the transcript remain below MR3. And on 11/13/2020, we welcome Leonardo with a spontaneous delivery at 40 weeks plus 1 day. The weight, the height, you can see it here. The patient at delivery was still in MR4. Breastfeeding was allowed. The last control on May 2022 was still MR4 or better, MR 4.5. And you can see that the strict monitoring could help us maintaining TFR with no need to restart interferon. And this has been possible through a multidisciplinary team cooperation that optimally managed both first and second pregnancy, succeeding of this happy ending. And this is Leonardo now. So what do we have learned about this conversation? First of all, that life is a lot more interesting than guidelines, and that not always guidelines can help you, because each case is singularly considered and should be managed not only by knowledge, that of course must be present, but also by a common sense. Also, also that breastfeeding can be allowed for patients if they are on interferon or in CCYR on MR3. And for the other things, maybe next year we can continue on this discussion. I would like to thank you all for your attention. The Indian Society that has invited me, and all my collaborators and friends.
Thank you so much, Dr. Elisabetta. That was beautiful. We knew about pregnancy and TKIs, but the in-depth discussion that you did and the cases that you presented was really an eye-opener. Fantastic. I think we will be able to do a much better job now. So we have some colleagues who would like to ask you some question. We'll start with Dr. Roshni.
Good evening, ma'am. So much.
Good evening.
Thank you so much. I had a couple of questions. In which situation would one advise a medical termination of pregnancy if one gets pregnant on imatinib between week 5 and week 12, as you mentioned?
Okay, I can answer the first question. There is audio coming back.
Yeah.
Okay, can you hear me now?
Yeah.
Okay. Concerning termination, this is something that we are mainly used as a common sense, meaning that the patient must be informed that there is a possibility of malformation, especially if imatinib was administered or other TKI throughout the whole organogenesis period. But we must consider that the percentage of those abnormalities are around 20%, meaning that 80% of patients still can have no problem about the exposure to TKIs. Besides, the abnormalities are so peculiar that usually are easily identifiable when you screen the patient with the ultrasound. So if the patient doesn't feel comfortable about waiting and maybe going through an interruption, not before the 3rd month of gestation, she can continue the pregnancy, and we can help following her in strict contact with OBGYNs and the other colleagues.
The next question is, if a patient is diagnosed as CML during pregnancy, how frequently should one monitor the CBC?
Okay, also this, we start monitoring every 2 weeks. But if we can see that the CBC is stable, we tend to join controls with the pregnancy controls that are usually 1 month, 1 month and a half. But you check the CBC, you check the platelets, and you see, as you could see, our Kumari, our Reta, a patient, she was followed throughout the pregnancy, and she basically maintained her transcript as it was.
And how frequently should we monitor the BCR-able transcripts in patients who are not actually in that definition of TFR?
Also for this, we tend to monitor each month, but if you can see that the transcript is rising, of course we do it earlier. The same for the CBC. If you see that the white blood cells or the platelets are rising, it's better to monitor every 15 days instead of 1 month, 1 month and a half. I would not go more than 1 month anyway. With PCR, I can go more than 1 month, because if I can see that the transcript is stable, also after the patient has stopped therapy, I can do like 1 month and a half, 2 months, like this. Not more than that anyway.
When do you all use low molecular weight heparin? With what kind of platelet counts during pregnancy?
During pregnancy, usually I use it when platelets are above 500,000. Because we consider that the pregnancy is a procoagulant situation, leukemia is a procoagulant situation, and also you need to consider white blood cells other than only the platelets.
Thank you so much, ma'am.
Thank you.
Dr.
There's a question on the chat.
Yeah, you can answer that, yes.
Okay. Okay. CML chronic phase on imatinib 400 milligrams. After 9 months, patient came with 2 months pregnancy and she was continuing imatinib. She's not affording interferon. What to do? Stop immediately imatinib and wait that placenta is formed. Check on the molecular biology, and when I would say molecular biology rises above 1, meaning that you're kind of losing a complete molecular cytogenetic, you can restart on imatinib after this period.
Thank you. Dr. Verma.
Thank you, ma'am. So just wanted regarding the fetal monitoring. So those patients who are exposed with imatinib and continuing with the pregnancy. So do you recommend any, specific fetal monitoring like targeted imaging for the fetus or something at any specific time point to detect the congenital abnormalities?
Usually at 21 weeks of pregnancy or around this period is when you in Italy do the morphological ultrasound, and we try to stay around 18-20 weeks when the patient has been exposed, and we try to we are lucky because we have a team that works together since, I must say, 30 years. First, we were working only with lymphomas, but now we are working in leukemias and thalassemias, but now we are working also with CMLs, and they perform all the controls, and they know what to search, and we collaborate very much. But I think it's not going to be difficult for you to identify someone that is interested in the subject and maybe could screen those patients that not, at least in Italy, unfortunately, they don't do that many trials in Italy, but it's not something that happens every day, so.
Thank you.
Thank you.
Thank you.
Dr. Chirag.
Yes, wonderful discussion. Case-based was excellent. Thank you so much. The TKI, at least imatinib, seems to be safe. So why not this strategy of stopping in the first trimester and restarting in the third trimester instead of PEG interferon? Why not that as the most common strategy?
Okay, there are some points that need to take into consideration. The first one, I can turn upside down your question and tell you what another colleague from France, Philippe Rousselot, asked me. Why do you treat those patients, knowing that CML is not evolving in blast crisis during 9 months, especially if those are patients already treated and already in remission? Why do you fear about blast crisis? Because this is the only one that you should fear. So why don't you wait that you lose, for example, complete hematologic response before starting to treat? The second is, according to your question, one other colleague, Carlo Gambacorti, another expert in CML, said, why do you want to treat those patients, for example, at onset with interferon if you need to treat them once you know that the imatinib is not passing the placenta or nilotinib is also pretty safe? And so why don't you treat those patients with the best available drug instead of doing interferon? And then I'll give you another point of view. The patient that I presented that had a baby, she said, I want to breastfeed. So with imatinib is not really suggested to breastfeed, even if the concentration of imatinib in breast milk is equal to the plasma concentration. that is way below the concentration of the drug that you give by mouth. So you can also assume that the baby is not assuming, is assuming a neglectable amount of imatinib, and so you could give breast milk. But you know that for breast milk, you have artificial milk. So this is something that is not really too bad about not doing it, but this is what happens. So each solution can be valid. There is no right question. So you must consider the patient. You must consider all the situation. For example, you told me that some patients cannot afford interferon. So this is not a problem that we have, fortunately, in our country, because we have a social security that gives drug. The other problem is that we cannot find sometimes interferon because they are going out of production. For this, I really hope that ROPEG is not, of course, interested in this niche of patients during pregnancy, but still, there are not only those patients, there are different illnesses that can still achieve good results by treatment with interferon. So many situations, many variables should be considered. And I'm happy that you posed this question, because I could give you, one coin and the other side of the coin. As you could see with the case report that I presented, we can say one thing and then the real life is completely different. So try to choose the best using knowledge and common sense.
Thank you. Dr. Radhika.
Thank you for the presentation. I had a patient similar to your case number 5. Unlike your patient, my patient has completed her family. This lady, in spite of switching over between 3 TKIs, still she fluctuates between MR2 and MR3. The PCR API transcript, neither it increases nor it regresses.
You're talking about someone. Sorry, you're talking about someone that is in pregnancy now?
No, ma'am.
No, normal, before pregnancy. Okay.
Yeah, after pregnancy, 35 years, she completed her family.
Okay.
She completed her family.
Yes.
But in spite of switching over between 3 TKIs, she still maintains an MR2 or MR3.
Okay.
She has gone into MR4.5 or MR4. So
okay, so you're talking about what to do with this patient.
For the last 6 to 7 years, I have been managing this patient with nilotinib, maintaining an MR2 or MR3. It neither worsens nor it improves.
Yes, I understand. Okay. So there are different new TKIs that are coming up. One actually is coming from India that is called Spark vodobatinib. I don't know if you know about that. It's an Indian drug, and has shown very good results in patients that have been treated also with many TKI, also with ponatinib, and did not achieve good responses. Another drug that could be thought about being used is the ABL001, the new Novartis, now it slipped to my mind the commercial name.
Asciminib.
Asciminib, yes, exactly, asciminib. Interferon, as you could see, is not a bad drug. We had more than one patient that we treated with interferon in conjunction with the TKIs, mainly ponatinib, that for us is at present the last situation. I don't know, in the next future we will have asciminib too, but now we have ponatinib as the most potent drug. And so you can consider either an association with another drug with a different mechanism of action, or switch drug. It is true, however, that those patients usually, if how many years she has been treated?
last 6 to 7 years, I'm managing her with nilotinib. She is happy, I'm happy. The only thing is she has reached an MR2 or MR3.
So she's 7 years treated, right?
7 years on
7 years.
She's happy.
Okay.
Yeah.
I think that I would be happy too, because if she would have come with a blast crisis, she would have come with a blast crisis already. 7 years, she's probably in complete cytogenetic remission. You can stay with this drug.
Yeah, I have been
until something else is coming up. Actually, I don't know if I can say, but I'll say it anyway. There's a project coming up as an experimental protocol that uses patients with nilotinib that could not be able to enter TFR, that will be added with asciminib, because asciminib is an association drug, because it has a different side of action than TKIs, and it enhances the effect of TKIs. And so there is this experimental protocol that will start in the next months that associates asciminib with nilotinib. So maybe in a couple of years you can take this into consideration, or just stay with this drug and all be happy.
My second question: what is the safest TKI during breastfeeding, ma'am? During breastfeeding,
there is no safe TKI actually, because they all are excreted in the milk, but a very little concentration. So I would not give it to a baby if I have the possibility to use an artificial milk. But for example, imatinib has been used during breastfeeding. I don't know about the other drugs.
Should I stop breastfeeding when patient is on TKI?
Patient on TKI that breastfed while on imatinib therapy after delivery.
Thank you, ma'am. That was useful.
Thank you. There's a paper of Carlo Gambacorti. I think that you can find this paper.
Thank you.
But I would not feel comfortable in saying go ahead with the breastfeeding.
How do you counsel?
No, I consider interferon. If you want to breastfeed, then need to be treated interferon. Or better, no treatment, and you breastfeed for 3 months, and then you start treatment after 3 months. Also, this can be considered.
Thank you. Thanks.
Thank you, Dr. Chirag, and then Dr. Krishna.
So just going back to this stopping drug during pregnancy, and we have always held the feeling that non-compliance with treatment, stopping, increases the risk ultimately of acquiring mutations and going into blast crisis. So whereas what I'm hearing today is different, that even if you lose hematologic response, even if you have high counts, it is still okay. So that's kind of very different from what we have been telling patients. Also, we scold patients for stopping for several months, and then they come back to us. So does that not change the natural history? If you stop, there is no increase in the risk over the years?
Apparently, there's no increased risk. We are trying to solve this problem also in processing that will be done in the next probably year. The database coming from ELN, and also a smaller database coming from Italy. The message is that here you don't have only patient and illness, you have also baby. And if we are talking about that, it means that the patient wants to pursue the pregnancy. So you need to find a compromise. The compromise is based on our knowledge in a patient at onset, if you check the risk factors and you see that is a chronic phase, that maybe the SOCAL is low and the patient has not many blasts, and she can go through those 16 weeks of pregnancy, you are pretty safe and you can start treatment at this time. If a patient has been treated already, you supposedly have a patient that is at least in complete hematologic remission and complete cytogenetic remission, if not in deep molecular remission. Also for this patient that has responded to TKI, stopping the therapy for a few weeks or a little months, that could be, you know, let's say the 3 months, the first 3 months, but then if you count is less than 3 months, is probably very uncommon that she could evolve. On the contrary, if you have a patient that starts a pregnancy because she was not responding to this, not responding to that, maybe she doesn't have also complete hematologic remission. This is a patient that is at risk anyway. So it's not really probably the stop of the treatment that is not working perfectly that will allow the potential clone to come up.
Thank you. Thank you. Dr. Krishna.
Thank you very much for the highlighting various scenarios. So I understand the best scenario would be a woman wanting to get pregnant when she's a TFR candidate. If she's not a TFR candidate, and if she's in a hurry, within, let us say, within 2 years of diagnosis, would you still allow her to get pregnant? I just want to get re-clarified.
Okay, basically no. Actually, this patient that I presented, she wanted to get pregnant 1 year after treatment. She was not even in MR3 and she already wanted to get pregnant. And I said, let's wait at least another year. And we waited only because COVID came up, because otherwise she would have get pregnant earlier. Sometimes you can explain, but you cannot enter in the mind of someone. You suggest which is the best scenario, then is the patient that tells you what to do, or she can just get pregnant and she doesn't know, she didn't want to, but you know, in some way she did. And so you can give her all your experience in helping her getting through the pregnancy in the best way. That's what we can do. Sometimes we cannot intervene on choices.
But the best scenario is a TFR candidate. Is it correct?
Of course. But if you could see the second case that I presented, the patient was in MR4 since 4 years. She stopped treatment. She got pregnant. In 3 months, she lost MR3. While the other patient that kind of never responded, and she supposedly had a resistant illness that responded only to ponatinib and interferon, and then she maintained the remission under ponatinib. She stopped treatment, and since 7 March 2020, she's in TFR. This was someone that was going directly through allogeneic bone marrow transplant. So you never know what can happen. The patient must be aware, the patient and the partner, of course, of the risk and of the advantages. And we are there only to help the nature, but we don't know how the nature can turn. So we give them all our experience and all our support to do it the best way in our science and conscience. Is this a way that you say also? Okay.
Yeah, thank you.
Thank you.
Excellent answer. Wonderful. There are 2 questions in the chat box if you would like to answer. One is, my question is, what is the incidence of fetal congenital abnormalities in a patient of CML. One of my young patient has showed this abnormality with high alpha fetoprotein with USG abnormality, with sonography abnormality. Is that an indication to terminate the pregnancy? She's on dasatinib with MMR2.
This means that she's still treated with dasatinib or she stopped dasatinib?
Looks like she's still on dasatinib.
She's still on dasatinib. She should stop immediately dasatinib and understand which kind of abnormality is that. If it is an abnormality that is life-threatening, or if this is something that can be managed also maybe with small surgery after the baby is born. Not an easy situation, but it doesn't say which kind of abnormality they identified. But the risk is high because dasatinib is more than 50%.
The last question is about hydroxyurea. Can it be used during the first trimester?
We don't like using hydroxyurea. It's still an alkylating drug. Actually, we used in one patient before TKI, the patient was not responding to interferon, and she wanted to get pregnant. It was 1999. And she said, listen, I wanted to get pregnant with you or without you, because I have a project with my husband and I don't want to leave our project dying. I can go out from here and get hit by a car and die. And so I don't want CML to conditionate all my life. And it was 1999, the prognosis was 5 years. So we said, okay, let's do whatever. You're well aware about the risk, not only for the baby, but also for you, that you can die in 5 years. But she was right at the end. We treat her with hydroxyurea, not in the first trimester. We treated her after in the third trimester, when white blood cells were going way up. And I remember that she delivered the babies with a cesarean section a little earlier. And the obstetrician said, I've never seen a placenta like that. It had multiple thrombosis. It was small, but the baby was happily fine. He's now 23, is going to the university, plays soccer, and no problems at all. But I would not suggest using hydroxyurea in the first trimester.
Sure. Thank you. That was great. Lecture was fantastic. And the question and answer session and the cases that you discussed, out of this world. Great. Thank you so much, Dr. Elisabetta. And we have Dr. Manoj Kumar here for the official vote of thanks.
Can I finish saying something?
Yes, please.
Okay. First, thank you all for having me here. And I would maybe, I don't think we have any case from India, but I would like to give you access to the European Leukemia Net, because there are also people from non-European countries. In science, we don't have borders, so we don't do wars. So we are happy to join all the people that would like to. And so I would maybe leave my email address. You can give it to people that are interested. And we are, yeah, you give the address and they can get in touch with me or Ekaterina to join the ELN Association for this database that is important for all of us. Thank you.
Thank you so much. Yes. Yes, Dr. Manoj, go ahead. Or I think he's not there. Okay, in that case, on behalf of Mumbai Hematology Group, I thank Dr. Elisabetta. All the discussants who are present over here, all the audience, and we have audience from almost 25 plus countries today who have heard you and other speakers. And lastly, the event manager team from Kalpesh. So Good night to everybody in India, and wonderful evening. Dr. Elisabetta, to you. Bye-bye.
Thank you.
Thank you for making us rich with knowledge. Thank you. Bye-bye.
Bye-bye.